Welcome to the ABCs of MIPS, our monthly broadcast looking at how the merit-based incentive payments will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for tuning in today. On this program, we address your questions covering the full spectrum of the payment program alphabet, including MU, PQRS, APM, VBM, MIPS, and more. On today's program, we're going to discuss the quality payment program and alternative payment models. Our expert from SA Ignite today is Matt Fusen. Matt recently joined SA Ignite from Allscripts as Director of Solutions Consulting. He is an expert on the industry's transition to value-based care, MACRA, the Quality Payment Program, APMs, and other CMS Innovation Center models. Matt, I'm going to quickly turn this presentation over to you to start, and I want to remind the audience to use the question box found on the dashboard on the right side to pose a question. We will leave time for Q&A. So Matt, I'm going to turn this over to you and go on mute.
Great, thanks Carol, and thanks everybody for joining. We took a lot of the previous questions that had come in from our previous sessions and used that to really formulate the deck and the presentation that we put together here. So as we go through it, hope to be answering a lot of your questions. As Carol said, we've left time at the end to take more questions, and looking forward to a great session. So pretty simple agenda today. We don't have a lot of slides because this is a really complex set of information between alternative payment models and then qualifying professionals. So not many slides. We'll spend time on each slide, go through the different types of alternative payment models referenced in the quality payment program, dive into the advanced APMs component, talk more about what MIPS APMs are and what the impact of that is, and of course the APM scoring standard. So this slide's a little busy. We're going to walk through it very slowly and really tackle what are all the different types of APMs in QPP. So if we start over on the left side with MIPS, of course we know that's the default. Everybody that doesn't meet some sort of exception to MIPS or QPP participation falls into MIPS, and that's where you start. Then we'll come along the bottom and speak to the different types of APMs. And we'll continue to reference those different types throughout the slide. So we'll build on the knowledge. So of course, what we all know is the advanced APMs. And the advanced APMs fit into the advanced APM track. They have very specific requirements that were set in the MACRA legislation that then CMS can alter to some degree, but they must use certified EHR technology. Payment has to be based on quality measures comparable to MIPS. And the final piece is where CMS made an adjustment, how much financial risk they must bear to be determined in advanced APM. And we'll talk more about that. But if you're in an advanced APM and you hit thresholds that we'll go over in a bit, you would be in the advanced APM track, and that's the track that pays the 5% bonus, and then you're excluded from MIPS. Then we have MIPS APMs. So MIPS APMs have a certain set of standards as defined in the QPP final rule. They must contain eligible clinicians as participants. They must hold their participants accountable for the cost and quality of care. And what you'll see are MIPS APMs can be advanced APMs. Advanced APMs can be MIPS APMs, or they could be neither. And again, we'll build on that as we go through with examples. Typically, the MIPS APM, the one that we're seeing right now, do not have two-sided risk, and that's what's keeping them from being an advanced APM. And then ultimately, there are just APMs, what we have titled other APMs. So those are all of the other APMs that CMS has defined, which is currently 21 different models. So through the CMS Innovation Center, they create and test alternative payment models. That's what that bucket is. So advanced APMs, MIPS APMs, and then APMs are the three variations. And we'll talk about those as we move through the deck. So let's talk about advanced APMs and some of the significant changes that occurred between the proposed and final rule. One of the biggest pieces of feedback and source of comments that CMS received was around the low number of available advanced APMs for clinicians to participate in. So, of course, CMS is promoting over and over, move from MIPS into advanced APMs. That's the roadmap we want everybody to follow, but there were limited options. So they took a couple steps to really resolve that. One of the biggest things they did was they changed that burden of financial risk definition. So they lowered that, which then makes more options available for advanced APMs. That, coupled with the other things we're going to talk about here, CMS is estimating now that 20 to 25% of eligible clinicians can participate in an advanced APM track in 2018. They will have the option to do it and can do it if they choose to take that path. That's a significant increase from where they were estimating in the proposed rule. Another big announcement that came out with the final rule was the announcement of MSSP Track 1 Plus that they are going to develop. That's going to be an advanced alternative payment model in 2018. So again, CMS received a lot of feedback, a lot of comments that over 400 different Track 1 ACOs exist. CMS heavily promoting that, everybody was joining it, and then QPP comes out and really almost penalizes people for being in ACO Track 1. So this is the attempt for CMS to create a very clear path for ACO Track 1s to move into an advanced alternative payment model without having to go all the way to Track 2 or 3. They will let current Track 1s move into Track 1 Plus during their current contract period. So usually you have to wait till your 3-year period's over to let people move during that contract period, as well as let others apply for that. So we expect more details on what Track 1 Plus looks like and the requirement later this year or early next year, with the application process being the first half of 2017. And then CMS plans to reopen current models to allow more participants. So, as you know, with alternative payment models, every one of them has a different registration, application, acceptance process. Some, like MSSP Track 1, 2, and 3, is a yearly application process. Others, like CPC Plus, had been a one-time application and then it was closed for 5 years. Well, now CMS is investigating which of those they can reopen. CPC Plus is what is anticipated to be opened up for additional participation. So if we take a look at 2017 to stay focused on what's right in front of us, 2017 approved advanced alternative payment models for the final rule, the same 5 that were in the proposed rule, so Track 2 and 3, Next Gen ACO, CPC Plus, and of course we don't know yet who's been accepted to participate in CPC Plus, and then a comprehensive ESRD model, or as many people know as ESCO. And then you see one additional, the oncology care model. The oncology care model originally only accepted 2-sided risk in year 2 of the model. CMS changed that. So anybody participating in the oncology care model can choose to move to 2-sided risk during the first performance year, so they could become an advanced APM in 2017. With the advanced APM, and to be in the advanced APM track and out of MIPS, there's really 2 criteria. First criteria is participation in an advanced APM. The second criteria is to hit thresholds that then allow you to participate in the advanced APM track, which then gets you the 5% bonus. So the 2017 thresholds also hold true for 2018. For the first 2 performance years, these are the thresholds that you need to get over to then be fully into the advanced alternative payment model track. So 25% of payments, that is reimbursements, or 20% of your patients. So you would either see those reimbursements or those patients hit those percentages through your advanced alternative payment model, as opposed to all of the Medicare beneficiaries that you see, so numerator, denominator. And then the 5% bonus is a lump sum bonus payment, and that will be paid in 2019. based on 2018 reimbursement data. So wanted to take a look and say, okay, this is 2017, and much of what we talk about is the multi-year view of this, as this is, not 1 year, 2 year, it is our future moving forward. So 2017, those models will carry over. And then let's look at 2018. This has already been proposed by CMS in some of their announcements. So the Track 1 Plus that we spoke about, they have referenced new voluntary bundled payment model. Very little detail about what that is, but generally they are learning from their Bundled Payment for Care Initiative, or BPCI, that's been up and running in the Innovation Center for a while. So more than likely, some of those existing BPCI models will inform these new voluntary bundled payment models. We also have the Comprehensive Care for Joint Replacement. This model started earlier this year. It was the first mandatory participation model, bundled payment model out of CMS's Innovation Center. They're going to tweak that model so it meets the criteria we reviewed earlier to be an advanced alternative payment model. It's not clear if they're going to also open up participation or open up additional areas of the country, or if it will just remain for those that are through the mandatory participation. And we have the cardiac rehabilitation model. This was announced earlier this year in July. It is currently proposed as another mandatory participation model, and they're making the changes there to make sure it meets the criteria for an advanced alternative payment model. And then, of course, what else will be coming? And when you look at this, one of the things that's important to put together is already into the second performance year, there's 10 and more than likely 10 different advanced alternative payment models that you can choose to participate in, of course, depending on your practice and your specialty and your area of location. So not everything will be for everybody, but it's a pretty broad mix. Understanding all of those options, and then of course comparing those options against each other, as well as comparing those options against MIPS, is really important. And one of the things CMS calls out is not to just make a basic assumption that my best option is an advanced APM. While that gives you plus 5% lump sum payment and excludes you from MIPS, you may be opening yourself up to more risk than the 5% would cover, and you would ultimately net and be in a worse situation. So the one call out here is really go to study what these options mean to you as you plan out your future. And the other is think about any organization of a little bit of size is more than likely going to have eligible clinicians participating in multiple of these models at any given time, and possibly another cohort of clinicians in MIPS. So it is not just a, I'll be in MIPS or I'll be in an advanced alternative payment model. More than likely for larger organizations, it's going to be some set in MIPS, some set in potentially an ACO, some primary care and CPC plus, some orthos in comprehensive care for joint replacement because it's mandatory. So again, the complexity of managing this continues to build as we move forward. So we talked a little bit about the APM entity level on our last call. Got a lot of questions about that. So I'm going to spend some time here explaining the structure. And then on the next slide, what we'll walk through is how those thresholds apply to what levels and what that then means from a qualifying participant or partially qualified participant. So first thing to think of is at that highest level where you see cost qual ACO, I just invented the name, cost quality, very inventive, and that is meant to represent a legal entity. So there's the advanced APM models. So MSSP Track 2 is an advanced APM model. Then there's a legal entity that participates in that model, and that's what we see at the top of the line. And that's referred to as the APM entity. Within the APM entity, so that Track 2 ACO is made up of participant TINs. So across that middle line, you see are the APM participant TINs. And then the third component of this are the eligible clinicians. So the APM participant structure is three-level. It's that APM entity at the highest level, APM participant TINs in the middle, and then eligible clinicians that report or are part of those participating TINs. Couple important things here to call out. Your thresholds that we're going to talk about on the next slide, those are met at the APM entity level, not at the individual APM participant TIN level or the eligible clinician level. So, to go through an example, if you are group 1 and you are participating in an advanced APM and you run your own data to see where you are against those thresholds, and you find out that you're going to check your payment data, your reimbursement data, hey, I'm going to be at 30%, I'm good. If group 2 and group 3 are both at 10% and the weighting works out, in reality, you will not hit the payment threshold because it's at the APM entity level, which then means you would have to either participate in MIPS one way or another. You could choose not to, we'll talk about that, or be fully into it. So what it really calls out is these ACO structures, and depending on how they're built, transparency into your partners in all of these advanced alternative payment models gets very important to understand where you're at moving through the year. The other component is anytime you need to participate in MIPS, and we'll talk about what those reasons would be, but let's take a track 1 or easy instance. Everybody in a track 1 ACO will get the same MIPS final score. So regardless of what happens at the group 1, group 2, group 3 level, at the individual eligible clinician level, everybody will get the same score, all the data rolled up to the APM entity level. There we go. So let's walk through participant qualification. So I'm sure you've seen QP, qualified professional, partially qualified professional. How do those come into play? So walk through some examples. So again, leveraging our APM entity example from before, and for 2017 and 2018 performance years, these are the thresholds. They go up in future years, but for the next two, these are the thresholds. If you exceed those thresholds, you are then considered a qualified participant. Everybody participating in the APM entity, so everybody down at that clinician level is considered a qualified participant. You are in the advanced APM track. You are exempt from MIPS, and you would receive the 5% lump sum bonus. So that's the easiest scenario. But CMS wanted to provide kind of a soft landing zone, for lack of a better word. So instead of saying, hey, it's a hard cutoff, you're at 25%, you're in advanced APMs, if you're 24%, you're not, and you got to go straight MIPS, they created this middle zone, which they call partially qualified participants. So if you see the breakdowns, payments, you get between 20 and 24, or patients 10 to 19%. If you meet those through your advanced APM, you would be considered a partially qualified participant. What that means is you have the option to participate in MIPS or the option to do nothing. So you would not be in the advanced alternative payment model track, you would not participate in MIPS, you would not see a reimbursement adjustment. But you could choose to participate in MIPS. If you do, you would use the APM scoring standards that we'll talk about in a little bit. But an important thing here is that decision to participate in MIPS or not is again at the APM entity level. So it's all in or all out. You cannot make those decisions at the individual group TIN participation level or individual clinician. And then ultimately, you could be in an advanced alternative payment model, but if you don't hit the thresholds to even be a PQP, so you fall below 20% or below 10%, then essentially you're deemed an eligible clinician that's participating in a MIPS APM. And then you would follow the rules based on the APM scoring standard for that specific MIPS APM. So MIPS APMs, this is a great, just very simple view of what we have from a MIPS APM's perspective. And for 2017, we're kind of lucky because there are no advanced APMs that are not MIPS APMs. And that's important because of what we just talked about. If you're in an advanced APM and you do not hit your thresholds and have to participate in MIPS one way or the other, then you use the APM scoring standard that we'll look at here, I think, on the next slide. 2018 and beyond, that doesn't have to be the case. There could be an advanced APM that is not a MIPS APM. Then for 2017, we have two APMs that are MIPS APMs but not advanced. That's your MSSP Track 1 and Oncology Care Model One-Sided Risk. And as we talk about how the scoring standard works, you'll see why that matters. So the APM scoring standard applies to any of those MIPS APMs we've been talking about. For the non-advanced APMs, this is what you will use for generating your MIPS score. For any of the advanced APMs, if you don't hit the thresholds, then you default back into this table and use this scoring standard to participate in MIPS. So the second column from the left, we just put in there for a reference. So your standard MIPS scoring, as we know for 2017, was adjusted in the final rule. So for quality, you're going to have 60%. ACI, which was MU, right, 25%. IA, which is renamed, it was CPIA, now it's just IA, is 15%, and they re-rated cost to 0 for 2017. An important call out there to remember is in 2018, cost comes back, and by statute, in 2019, cost must account for 30% of your MIPS score. So keep that in mind again as you're preparing your multi-year roadmap. Cost is only gone this year and then ramps up quickly. So then let's step into our first example for using the APM scoring standard. For MSSPs or next-gen ACOs, so in this case, if you're a Track 1 ACO, which we know we have many of, over 400 right now in the country, you will use this scoring standard for your participation in MIPS. And we'll go into a more detailed discussion of Track 1 and how that'll work on the next slide. And next-gen. So if you're in Track 2 or 3 or next-gen, you don't hit your thresholds, this is what you will use. You will use these breakdowns between quality API and IA. Now what's nice is CMS has already determined that for 2017, all of the advanced alternative payment models, or I should say MIPS APMs especially, are already going to get full credit for the IA category. So for Track 1, or if you don't hit the thresholds, you would get the full 20% for IA without taking any action, and then you would be performing on quality and ACI. For the other MIPS APMs, so this would be CPC Plus if you don't hit the threshold, or SQO, or especially Oncology Care Model One-Sided Risk, you're going to use the scoring standard in the last column. So they reweight quality to 0 with the thought that the APM that they're participating in is already scoring and managing quality, so they don't want to cause a double reporting or a double management. So then 75% of your score is going to come from the ACI, which is really then where you have your control, and you'll get the full contingent of 25% for IA. So as you're going through understanding the scoring standard, where you fit into these columns based on where your participation is, and then having an understanding of where you're going to fall out with your thresholds, those are all components that need to come into play as you're planning what 2017 is going to look like as it unfolds for you. So as I said, a lot of the questions that we got were specific to Track 1 because we have, so many participants in Track 1. As we just saw on the previous slide, 50% of that score is going to come from quality, 30% from ACI, and 20% from IA. Let's start on the quality. So for Track 1 ACO, the 33 measures that are reported through the GPro web interface to support ACO, the ACO, will be used, a subset of those will be used for your quality category within the MIPS scoring. So 11 of the specific measures out of the quality section of that GPro web interface will be pulled to be used for scoring mechanisms that will determine what percentage of 50 you get based on the quality. So that's at your ACO level. None of the participating TINs need to submit any data for a Track 1 for the quality component. For ACI, that changes, and it's the responsibility of each of the participating TINs within Track 1 ACO to submit ACI, and it must be at the TIN level. So for a participating TIN, you must report ACI at the group level. You cannot choose to report that at the individual level. They being CMS, will take all of that ACI data, roll it up to the top, score that at an ACO level, weighting those based on the number of clinicians in each of the different practices. And that's how they will build your ACI score. So then your quality score will come from the 11 measures they use out of your GPro web interface submission. Your ACI score will come from that rolled up, consolidated, weighted average score from all of the TINs, and your IA will be full credit. Again, if you look at this and you look at your ACO Track 1 makeup, collaboration across those different TINs, transparency into those different TINs becomes very important moving into 2017 and beyond to get the best possible MIPS score and reimbursement that you can get. If you are really knocking out of the park on quality and ACI, but you are partnered with other TINs that maybe are not as advanced on ACI, that will have an impact, because remember, that score is shared at the APM level. So at the Track 1 ACO level, everybody will get that score and that same reimbursement. And that score, as we've talked about in previous webcasts, also means a lot to reputational, right? That's going to be publicly available, and we expect a lot of traction for how that data is going to be used in different apps and different ways by the private sector. So we wanted to leave a lot of time to be able to go through questions that people have. At this point, I'm going to turn it back over to Carol and see what questions we have.
All right. So since first question, we're going to dive in this pretty quick, and just a reminder, attendees, they can use the question form on the right side of the GoToWebinar dashboard to post their question. Since we were just talking about it, just to clarify that for the MSSP Track 1 ACO, all providers and mid-levels must meet ACI. Just to clarify that, correct?
Certainly. So per the ACO standard, you only need to have the primary care physicians meet what was the meaningful use standard. But for the MIPS scoring, all of the eligible clinicians, so providers and mid-levels, need to perform against ACI, because at the group level, participating TIN level, each of those have to report as a group, and once you report as a group, all of the eligible clinicians are in play. So that is different. Now, it's not the ACO that's changing that. For the ACO, it still is the primary care. This is for your specific MIPS ACI score.
All right. Do providers and ACOs have to report on ACO measures and also choose 6 quality measures?
Great question. No. So the way it works is CMS dictates, as we know, what is part of GPro web interface. So they set the measures, whatever measures they set, and those measures are finalized for 2017. They're in the final rule. That is what every member of the ACO will perform against. So there is no need to select measures or do any level of reporting at the individual group level TINs for quality component of ACO.
Okay. What is the final definition of a recognized PCMH, and what is the impact of being recognized as a PCMH in 2017?
So that was one of the hottest topics after the proposed rule was, where is PCMH going to end up? So they did a couple things to change it. The biggest thing is they expanded the definition of a recognized PCMH. So it is across nationally recognized accredited bodies, which was in the previous or the proposed rule. Some of those NCQA, Joint Commission Design, Utilization Review Accreditation Commission. But then they also made it more flexible and changed the definition. So by definition now, for a national program or from a regional or state program, private payer or other body, it administers patient-centered medical home accreditation and certifies 500 or more practices for patient-centered medical home. And this can be found on page 685 of the final rule if you want to go reference it. So there's some work that you can do to find out when I get it or not.
Page 685. Out of it, it was over 2,000 pages. The final rule, wasn't it?
Absolutely.
It was a tome. Yeah, yeah. So this is a multiple part question. My multi-specialty practice is all under one TIN. One department, family medicine, has applied for C+, C+. If they are approved, how will that translate for all providers in the TIN? And will family medicine providers be eligible for APM? And finally, how will CMS differentiate these providers from all the others?
So this is a great question, and it has all those parts because it has some complexity to it.
Yeah.
And when we were looking at the slide, the APM, advanced APM slide with all the boxes on it, this was one of those types of scenarios where you're going to be managing multiple programs. So in this instance, CPC Plus, Comprehensive Primary Care Plus, is just for primary care physicians, obviously, so the family medicine. So just to use an example with some simple numbers, if you have 10 clinicians in your group and 5 of those clinicians are going to be part of CPC Plus, those 5 clinicians, assuming they hit the threshold, will be participating and considered part of an advanced APM. So those 5 clinicians would get the 5% lump sum bonus. The other 5 clinicians will have to participate in MIPS. You can either do individual reporting for those other 5 clinicians, or you could still do group reporting, and it may be beneficial to do group reporting because for group reporting, they will use the data of all 10 clinicians. So they'll use the data for even those that will be in CPC Plus. That will generate your MIPS score. The only difference is those clinicians participating in CPC Plus will not get a reimbursement adjustment because they're going to get the lump sum 5%. So a little confusing, but ultimately you can carve up the groups, and then you want to really understand, is my best option to report individually for the remaining, or is my best option to report as a group and leverage the data from primary care? And traditionally that has been the better option.
Okay. What differentiates advanced APMs from regular APMs? Perhaps nothing, just a naming convention? Or is the difference basically that these are geared toward larger organizations rather than individuals?
So good question, and it is not just naming convention. To be considered an advanced APM, it has to meet very specific criteria that was put into the MACRA legislation. That's where we were talking earlier. It is required to use certified EHR technology, use quality that is equivalent to quality components that are part of MIPS, and bear some sort of downside financial risk. So those combinations are needed, or else it cannot be considered an advanced APM. Now, advanced APMs come in various different sizes. For instance, one that you might think of as really for bigger organizations per se are these ACOs. I know of ACOs that are a combination of many smaller groups and providers, but also CPC Plus is a great example. Practices that have, a handful of primary care are going to be able to participate in an advanced alternative payment model through CPC Plus. So it's really meeting the requirements that were set out in the legislation and it is not meant to exclude or include anybody particular. It's all based on the design of the model.
Okie dokie. Sorry, hold on. At the beginning, you mentioned that Track 1 ACOs were not really advocated and folks should attempt to move into Track 2. Can you explain a little bit more about that?
Sure. Let me walk through it again, and hopefully I'll answer the question. So currently there's a Track 1, a Track 2, and a Track 3 in the MSSP program. Track 1 is not an advanced APM because it does not carry any downside risk. It's only shared savings. Track 2 and Track 3 are advanced APMs because they do have downside risk. What CMS has done, or they have announced, that they are creating a new track, so there'll be 4 in MSSP, Track 1 Plus. 1 Plus will have risk so that it can be considered an advanced alternative payment model, but that risk will be lower than what you would have to move into for 2 and 3. So in theory, it's more attractive for current Track 1 ACOs to move into what will be 1 Plus. They will hit the requirements to be advanced APM, which means they'll be auto MIPS and they'll get their 5% lump sum bonus, but they won't have to take on such a significant amount of risk as Track 2 and Track 3 do today.
In a Track 1 ACO, can you clarify or reiterate that you will need to attest to the that you will not need to attest to the ACI component separately if you're part of the Track 1 ACO? You will need to attest separately. Yeah. Do you attest separately or you don't?
You will need to attest separately in a Track 1 ACO. So
for ACI,
at the participant TIN level for ACI, each participating TIN will have to report ACI.
Got it. If a TIN who is currently part of that MSSP Track 1 wants to exit, do you know when they can do that and what the implications might be for MIPS?
So from an exit perspective, a lot of that has to do with what your contract is with the ACO, and the ACO contract with CMS. So that is usually a one-off and not a standard question. But I can answer what it means for you going through and when you make that choice. So CMS has implemented in the final rule participation snapshots, they're calling them. And they're going to do those 3 times throughout the year. And if you are billing through that ACO and on that ACO's registry as a participant for one of those snapshots, then you are considered part of that ACO even if you leave it afterwards. And those snapshots are March 31st, June 30th, and then August 31st.
Okay.
So if you're on that for any one of those 3 and you're billing through it, you're going to be in regardless of what else you do.
Since you mentioned those dates, it's a great segue in for the next question, which is for Track 1 ACO MIPS APM, please address the MDs who joined the group after the snapshot date of 8/31/2017. So they cannot be included in the MIPS APM scoring and have to report separately.
That's right. So it creates a scenario back to what we were talking about a little bit earlier was you're going to be managing different cohorts of clinicians in different programs at different states and time during a year. So anybody that joins after that last snapshot will have to perform and report via MIPS for that last 4 months of the year. It won't be until the following year that they would be considered part of your ACO.
Okay. Please clarify, you stated that all eligible clinicians under the ACO must participate in ACI. Does that mean only those clinicians under the ACO that exceed the low volume threshold need to participate in ACI?
So whenever you are then reporting as a group, as part of that ACO, all clinicians are in that ACO, so they are not excluded because of low volume thresholds.
Okie doke. How will CMS determine performance tied to quality measures? In other words, can provider predict the number of points they will earn based on how they compare to the MIPS benchmarks?
Absolutely. So one of the things that you can do throughout the year, and what we help clients with specifically, is exactly that. It is, how do I take the data that I have and then be able to run some analytics against it so that I understand as I'm going through the year how I'm scoring against those benchmarks. In this program, as we've talked about on previous webinars, as opposed to some of the previous programs, continuous quality improvement is critical, because you're scoring against everybody else. It's not get to a benchmark, then if I did that in August, I don't have to worry about it again the rest of the year. It is, I need to be continuously improving, and if you have that data on those different measures, you can specifically look at where should I put my resources to improve the most, to get the most points.
Okie doke. We have a large TIN with over 450 providers, and we have a small portion of those providers participating in the oncology care model. So we are trying to determine if the OCM participants can qualify as an advanced APM if they go with a two-sided risk track, or since the majority of the TIN will only qualify for MIPS, that our oncology providers will end up in MIPS by default. Any insight is appreciated.
Absolutely. So in that scenario, if the clinicians that are participating in the oncology care model do choose to go two-sided risk, and they hit the thresholds for 2017, those clinicians would be carved out at the end of the year. They would be considered advanced APM qualified participants. They would get the 5% bonus. Your overall TIN would still report your data as you have, and the TIN would, everybody in that TIN would get the score earned by the TIN, and then everybody except the OCM participants would get the reimbursements based on the score of the TIN.
All right. On slide 7, are you saying that within a group, ECs can be part of different advanced APMs? Oh my, wouldn't that be terribly confusing?
Yes. So you could, right? Having to manage it does get very confusing. It has the potential to get very confusing, right? And this puts a whole new light and spin on really managing your provider level data and knowing, are they hitting thresholds? Are they participating in what different APMs, whether those are advanced APMs or MIPS APMs? Are they low volume and going to potentially be excluded if you do individual reporting? There's differences for hospitalists or hospital-based clinicians. So you're absolutely right. It can happen, and then the management of that kind of really amps up starting in 2017, even more than what we've seen in the past.
All right, next question, and we are trying to get to as many questions as we can here as they are pouring in. Regarding the MIPS APM MSSP Track 1, how will the 11 or 33 quality measures that will determine our score be selected?
So the 11 are already selected. They were selected by CMS, and those are available in the final rule. And they are the 11 that have the 11 specific quality measures that have benchmarks. So you can find those. Those are out there on the QPP CMS website. They're also in the final rule, but they were selected by CMS.
Okay. And you guys have, I know you guys have lots of blog posts and FAQs and white papers on your website addressing a lot of these questions, and also CMS, of course, has their, at the cms.gov website has their list of FAQs as well. Please elaborate on scoring for ACI. Does every individual clinician under the TIN contribute a score for each measure, which is then aggregated to the TIN level and then again to the APM entity level?
Yes. Yep. So it is that roll up. It's a TIN level. Those clinicians are going to contribute to your TIN level score, and then if you have 10 TINs, you roll all 10 of those ACI scores up to the APM level, and they get aggregated again. At the APM level, they're aggregated and they're weighted. So if you have one TIN out of the 10 that's 1,000, ECs and one that's 10, they will have an equal contribution. If not equal, they will be weighted so the contribution represents the makeup of the different groups.
How will participants in the APM report the IA category? Do you know?
So for right now, for 2017, all of those have been given by CMS deemed to get full credit. So they don't actually have to report, is our understanding at this point, because being part of that advanced APM or MIPS APM, you're going to get full credit. Now, if the question is about a regular APM, let's call it, it's an attestation. In future years, they're talked about other reporting methods, but for 2017, anybody that reports IA will be via attestation.
So very similar to what they did, and of course, you do this, you attest to meaningful use.
That's right, and for meaningful use or ACI now, they again have talked about increasing the number of ways that you can report, but nobody expects that for 2017 reporting year, it will be anything more available than attestation.
Okay. Do next-gen ACOs have to submit ACI information if they become QPs or partial QPs who elect not to participate in MIPS?
No. So if you, as a QP, you definitely would not have to submit anything because you would be fully in the advanced APM track. If you're a partially qualified participant or a PQP, and you choose not to participate in MIPS, then no, you would not need to submit anything.
Okay. There's been confusion within our organization around Track 1 ACO and the length of participation. We can participate in either a 90-day reporting period or attempt to do a full year, correct? If we participate in only 90 days, are we eligible for the 500 million exceptional bonus pool?
Yes, so great question. So this is to provide a little background to provide context. This is in line with the announcement that CMS made and then put into the final rule that what they're calling pick your pace. So just a refresher on that, pick your pace allows, we'll call it level 1, which is as long as I submit some data at one point in time for the year, I can avoid any negative reimbursements. And then what this question is really referencing the next two options, which were report for a 90-day reporting period, and then you have the opportunity to get positive reimbursement. Or their third option was report full year data. And we've worked with CMS specifically, and there is not a difference for how you will get scored or your potential reimbursement between 90 days or a full year. The full year is promoted to continue to get people to get engaged, practice, right, for lack of a better word, put in the workflows, really hit 2018 ground running, and the way to do that the best is participate for the full year. But it won't have an impact on reimbursement or score, and it also does not have an impact on your eligibility to see some of that $500 million exceptional bonus money. So if you hit a MIPS score of 70 or higher, you would start realizing some of that exceptional bonus, exceptional performance bonus money.
Right. For Track 1 ACO for ACI, we have a tin in the ACO that has providers who use certified EHR technology cert, and we have some who don't have cert. Do all providers in a tin need to use certified EHR technology in order to get ACI points?
So, no, you will be able to get ACI points just when you're looking at your how many points you can get is what you will be constrained by. So you can, what's nice about what they changed for ACI as opposed to MU, where MU was all or nothing, now with ACI you can earn points, and you would be able to earn some set of points.
Because ACI, like meaningful use, is about using certified EHR technology.
That's right. That's right.
Right. Right. I know that the MS-SP quality metrics are posted, but does CMS have the benchmarks published too? And are these risk adjusted?
They are not. published yet. We're waiting for those to come out. And I believe they're risk adjusted. There was a lot of conversation back and forth on that. That's one I'm going to have to take a note on. But they have not been published yet.
Okay. If a practice, TIN, does group reporting and as some physicians qualify participants in the advanced APM, must these QPs still be included in group reporting?
So yes, so I believe I'm following, again, if we use the scenario of I have 10 ECs and all in one TIN, 5 of those are in an advanced APM. When you do your group reporting, it will be for data for all 10 of those. The score will then be generated based on data for all 10 of those, but only the 5 not participating in the advanced APM will have their reimbursement adjustments per the score generated.
Okay. CMS has a chart showing partial QP thresholds at 20% for payments and 10% for patients. Can you tell me what that is about?
So that's correct. So if there are the qualifying professionals, or I'm sorry, participants, and those are the thresholds of 25% for reimbursement and 20% for patients. Then, as you mentioned, it's the partially qualifying participants at 20 and 10. And what that means is if you have a threshold score that is in between for reimbursements 20 and 25, or for patients 10 and 20, you are considered a partially qualified participant, and then you have the option to participate in MIPS or not. You will not be in the advanced alternative payment model because you didn't hit that threshold, but there's kind of a landing zone there that CMS has created, and as an APM entity, you can choose to participate in MIPS or just choose to participate in nothing for that year.
Okay. If we currently have TINs which qualify as advanced APM and then their participation changes and they no longer qualify, are there any tips on how to track any potential change mid-year?
So I'm not sure that I have tips, unfortunately. That's one of those things where to operationalize the ability to manage these programs now across the year and the providers, I say I'm not so sure it's a tip. It's really good operational performance of knowing all the data about your providers and clinicians, who's participating in what, all those attributes, and having all of that data in a single source of truth, and then actively managing it, really. That's what it's going to come down to, is truly having that clinician level attributes, all the ones that are meaningful for QPP, and there's a lot of those, managing those in a single source of truth. That's going to give you the best chance for success.
Right. And just to remind everybody that obviously SA Ignite can help with that process as well. That's what you guys are doing, is helping clients, manage all of that. Just a couple more things. We've got just a few more minutes. So I'm going to take another question, and I remind everybody, because people have been chatting and asking. Actually, SA Ignite has a company page, but they also have a group called the MIPS, Merit-Based Incentive Program Group, that you can go to LinkedIn and search on, and you can find, and you can certainly follow some of the dialogue there. For those questions I didn't get to, please reach out to SA Ignite at info@saignite.com. And we will be back in December, I believe, for another event looking at the final rule. So one more question, and then we will wrap up for the day.
Sure.
I thought participants in an APM could also report quality at the individual level, and CMS would take the best score.
So there has been some confusion around that. We have gone back to CMS for clarification on that. I would say, check our website and our FAQs. We'll make sure that we have that in there. I can tell you definitively for ACOs, that is not the case. Some of the other models like OCM I don't believe it to be the case, but we're still waiting on a definitive answer from CMS. So I would suggest checking our FAQs. We'll get those updated as soon as we have the answer.
And as big as the final rule was, and as complex, and some of the attendees were asking about specific pages and sections about the final rule, I think CMS is still taking some comments about the final rule, correct?
That's right. So this is the kind of new world of CMS where it's a final rule with comments.
Right,
so CMS
right.
is still taking comments. And
it's not over until it's over.
That's right, and then it'll be a final rule with comments and comments and comments. So yes, it is still open for comments, and that was a 60-day window from when it was published.
Right, right. It was published mid-October, so that on or about mid-October. So by mid-December, that will be winding down. Matt, I want to thank you so much for tackling such a very complicated topic, and certainly macro is complicated anyway, but certainly the APM side of it is got an additional layer on top of that. For those of you who are attending, I will get a copy of the recording for viewing out to you by Monday, and look for notification of our upcoming event in December. We should have those details out in the next week or so. Matt, thanks again. Have a great Thanksgiving, and as well as everybody who attended today. We appreciate your time, and we'll see you and your other SA Ignite cohorts on next month's event.
Excellent. Thanks, Carol. Have a great Thanksgiving as well.
Thanks. Bye.
Bye-bye.